Hi, my name is Dr. Jason Mazzarella. Today we'll be discussing two special imaging studies and two court decisions. So, perfusion studies. The first perfusion study is qEEG. qEEG measures the electrical activity of the brain. Research has shown that this test is 96.59% sensitive for determining mild traumatic brain injury. The way it works is we get microvolts of electrical activity over different regions of the brain. Depending on the activity in microvolts, we can determine if an area of the brain is hyperactive, hypoactive, or functionally normal. In regards to impairment, findings of reduced brainwave activity can equate to 11 to 30% whole person impairment or more. The next test is SPECT scans. SPECT scans map brain vascular supply. Because damaged brain tissue normally shuts down on its own, we have reduced blood supply. This shows focal vascular defects which can be shown on SPECT scans. Research has shown SPECT scans to be approximately 50% sensitive for mild traumatic brain injury. More recent research in Canada has shown that SPECT scans can be actually up to 93% sensitive. In addition, research has shown whiplash brain. This results in abnormalities of glucose metabolism, characteristically through bilateral hypometabolism or hypoperfusion in the parietal occipital region. There are other factors as well that show different injury patterns. Of note, CT and MRI scans are typically normal. So perfusion studies have been used since the 1990s to help show injury patterns. These perfusion studies include perfusion MRI, fMRI, SPECT or PET scans, cerebral regional blood flow examinations, and qEEG. So what did the court say? The first perfusion study is SPECT scans. In Canada, in November of 2021, the courts found that SPECT scans failed to meet the reliability foundation test for novel scientific evidence. So was this because of the special test or because of the expert used? So the plaintiff expert, Dr. S, conducted a SPECT scan on the plaintiff and stated there was a previous traumatic brain injury. Dr. S provided evidence that he performs 50 to 60 SPECT scans per month. The problem is that these SPECT scans were not specific to whiplash, to car accidents, or to traumatic brain injury. The defense counsel hired a neurologist that provided evidence to the court that SPECT scans usage as a diagnostic tool for TBI was controversial. The court held that the use of SPECT scans was not novel in itself, however, the use of SPECT scans to diagnose TBI was. Now, the problem is not in the scan, but the experts. In the court findings, Dr. S, the plaintiff expert, conceded that his methodology had not been tested, but argued by its nature it was not susceptible to testing. Dr. S conceded that his work had not been published or peer-reviewed and that there are no peer-reviewed articles supporting his theory, which is actually incorrect. Dr. M, the defense expert, stated the use of SPECT to diagnose TBI is not supported by academic communities represented in teaching hospitals in the region. This is in fact incorrect as well, as a recent Canadian radiology study confirmed a 93% sensitivity to SPECT scans for TBI. So the experts determined the outcome of this case more so than the special testing. Our next special test is qEEG. In May 2021, a Florida court denied a defendant's DeBart motion to strike the plaintiff's expert testimony regarding qEEG. In this case, the defendant sought to bar the testimony of the interpretation of the qEEG. To support its motion, the defendant submitted only 3 articles that argued that qEEG for diagnosing mild traumatic brain injury have been prohibited by the American Academy of Neurology for over 20 years. What's noteworthy is one of the factors the ANA guidelines that were relied upon in this defense was retired in January of 2020 and is no longer an official position. Now with qEEG, one of the reasons is that computer technology has advanced to such a great degree that these tests are much more reliable now than they were in the 1990s. Contrasting the defendant's presentation, the plaintiff submitted numerous peer-reviewed articles comprising over 140 pages, including book chapters, scientific journals, for the usage of qEEG in the diagnosis of TBI. There's actually over 1,500 articles specific to this in Medline. The peer-reviewed literature produced by the plaintiff denied the error rate argument supported by the defendant and established the wide usage of qEEG as a diagnostic tool in the Veterans Administration's for traumatic brain injury. The plaintiff's expert, Dr. A and Dr. B, testified that they used qEEG in their everyday practices and they are familiar with the literature that they used to support their diagnosis of traumatic brain injury. Now, this is very important that they use the test in everyday practice and they are up to date on the literature. Due to their clinical experience, the court found that the plaintiff witnesses were persuasive enough to allow qEEG as a special test to diagnose traumatic brain injury in the courts. So the court findings. The defense presented two experts, Dr. M, a board-certified neurologist with a subspecialty in neurophysiology, and Dr. D, a neuropsychologist. While Dr. M testified that she did not believe qEEG was a valid test for the diagnosis of traumatic brain injury, she acknowledged that other doctors did use that test for that purpose. During cross-examination, the plaintiff demonstrated that Dr. M was unfamiliar with the software utilized by the plaintiff doctor, Dr. A, who was not an expert in interpreting it and did not examine the raw data generated by the qEEG. Dr. D also admitted that he was not qualified to administer or utilize a qEEG, nor was he an expert in qEEG in general. A surprising fact is the American Academy of Neurology actually states that less than 1% of neurologists use EEG and far fewer use qEEG. After the court conducted a DeBart analysis, they found Dr. A was qualified, her testimony was based on sufficient facts and data that utilized qEEG as a tool to help diagnose traumatic brain injury, and it was sufficiently reliable on scientific and valid data. So in this case, it wasn't the test that was approved, it was the expert's ability to read and utilize that test based on clinical practice and research. So in summary, the U.S. attorneys used doctors that performed qEEGs in office daily to assess and treat mild traumatic brain injury patients. The Canadian lawyers used a radiologist. Consider the picture of the wrist at the bottom of the screen. We can see a fractured radius. While a radiologist can say that there is a fracture, he or she cannot say from this picture alone that the fracture was due to a car accident, a slip and fall, a sports injury, or some other condition. The Canadian lawyers lost their case because of their choice in their expert. In the US, the lawyers questioned the expert's specific training on qEEG, which in fact most doctors will have none. This was then demonstrated by the plaintiff's request for the opposing doctor to read the output of the qEEG software. In Canada, the defense experts stated that SPECT was not supported by the academic community, and the plaintiff expert stated that his work was not published regarding TBI. So in Canada, the defense lawyers were able to get the plaintiff expert to show his weakness regarding mild traumatic brain injury and whiplash car accidents, but the plaintiff lawyers did not question the defense expert's understanding of mild traumatic brain injury associated with whiplash. So in summary, in the United States, a special test, qEEG, was approved to assist in the diagnosis of mild traumatic brain injury, whereas in Canada, a special test, SPECT scan, was denied as a novel diagnostic tool. So how was a winnable case lost? Number one, the lawyer needs to understand what to look for in an expert. The expert needs to know the research associated with the collision, in this case a motor vehicle accident related mild traumatic brain injury. The expert needs to understand causation patterns based on kinematic responses during the trauma mechanism. And the expert needs to be a leader in the field, allowing for scientific backing. Using a radiologist, even if this was the best radiologist in the country, just will not work because the radiologist cannot comment on causation. Number two, use an expert that also performs the service daily in clinical practice. There has to be a clinical experience correlation, otherwise the opinion is not tried and true. By having an expert that also treats and uses the methods being discussed in court, the expert's clinical knowledge becomes objective testimony instead of subjective testimony. Number three, use an expert that is familiar with the most up-to-date research. This is based off of Michigan case Craig versus Oakwood Hospitals. So to present medical evidence, the expert witness general guidelines include qualifications such as description of current practice and time in practice, nature and extent of relevant experience, teaching posts or experience, academic honors, awards, and certifications, and familiarity with the condition in the case. In Michigan, the courts found the educational and professional training of the expert witness, the area of specialization of the expert witness, and this is the crux, the length of time the expert witness has been engaged in the active practice of the specialty as key components to testify. So why your expert-specific training matters. Whiplash-specific training, education, and experience matters. The process is to determine if there is a causation, is there an injury, and is that injury significant? So first, crash forensics. Crash forensics looks at occupant kinematics, risk factors, and crash variables to determine injury potential. In this specific case, the patient sustained a subdermal hematoma. Now, this was a pretty easy, straightforward case because she sustained the injury, was taken via ambulance to the hospital, special imaging was done, and the subdermal hematoma was found. So there was no causation factor. But if we look at the kinematics of the collision and how we can use crash forensics to determine injury potential, we can see that we can use this to see what kind of injury potential is possible based on the collision variables. So with this woman, she was in a vehicle that had manufactured a specific racing style seat just for this year's manufacturing product. So with this seat, it was very stiff. So when she got hit, her body ramped up the seat and she hit the back of the B-pillar. Now we found evidence through the Insurance Institute for Highway Safety crash testing where there was biorid dummy responses similar to this. So now we have an injury causation pattern based on occupant kinematics, the principal direction of force, and collision variables. Now that we understand the kinematic response of an occupant, we can look to see if there's a specific injury pattern based on the collision vector, the head restraint position, pre-impact head posture, and other occupant kinematic reactions that are well known through the literature. By understanding crash forensics, we can determine an injury pattern. This is a pattern or location where we would expect to see an injury if an injury was present. Next, we can then take this information and look for changes in interhemispheric communication, perfusion patterns, gray and white matter volume levels to evaluate for an injury. This is why we can say, based on the crash forensics of the collision, we would expect to see a perfusion change or a communication change with a mild traumatic brain injury in this region of the brain. Based on special testing, and this could be any perfusion study, we can confirm or not confirm, depending on the results, that there is or is not a change in perfusion in this region. This will either show a causative association in the motor vehicle accident with the current symptomology and impairment of the client, or it will not. Lastly, as mentioned, the doctor needs to know whiplash and associated injury patterns at a true expert level. Why is this? By simply saying that the crash forensics of the collision suggest a mild traumatic brain injury potential is present, this is not sufficient for causation in my opinion, as there are a number of different types of mild traumatic brain injury that can occur based on crash forensics and occupant risk factors of the collision. Some examples. For mild traumatic brain injury, you could have a head trauma, a mild traumatic brain injury, a blood-brain barrier disruption, white or gray matter disruption, diffuse axonal injury, concussions, general cognitive processing slowing, stress, or reduced cerebral metabolism. Also, if we look at other related conditions such as chronic pain, there are different patterns of pain registered on special tests based on the type of chronic pain the person has. By suggesting that a person has generalized chronic pain and then trying to correlate that with special test findings, there will never be a high degree of sensitivity or specificity, as each person's chronic pain can be a different form of chronic pain registering with different patterns of coherence or perfusion in the brain. Even PTSD has different brain perfusion and coherence patterns based on if the PTSD is due to physical or emotional trauma. So as lawyers, the success of your case has to do a lot more with the expert you choose than the evidence you have. You need someone with a strong crash forensics and accident reconstruction background in order to understand injury potential and also what tests to use or complete to see if an injury is present. The doctor must treat these patients in clinical practice and also be up to date on all of the most current research. And this only happens when the doctor specializes in whiplash. Unless your expert is a whiplash specialist, there's a high likelihood that things will get overlooked and an impairment can either be attributed or not attributed to an MVA. If we look at the Medline citations for 2020, there was over 362,000 journal articles published. The year before, almost 900,000 journal articles. If we look at healthcare professions, there's over 144 different healthcare professions. If we look at one of those, neurology, there's over 24 subspecialties in that one specialty. So there's a great wealth of information out there on a great wealth of topics. If you don't have a doctor that specializes in whiplash, things can get missed. Our goal is to provide world-class education, treatment, and assessment of whiplash traumatology, and we're the only organization in the world that has been academically accredited to do so by the medical and chiropractic community in 29 countries.